We're just waiting for folks to hop in. Okay. Can everyone hear me? I can't see or hear anyone, so. I will assume that is a yes.
Yes.
Okay, I just want to make sure. I have no way of knowing. Thank you, Marion. So today I was hoping to, first of all, answer any questions that you might have so far with the SAS tutorials or anything else in the class. And I would also like to go through with you an example of using SAS for the types of questions that either as a healthcare admin concentration person, someone who wants to do research, the kinds of things that we would actually do using SAS, just to provide an extra amount of motivation for you guys to learn this software, to kind of see where it's all headed. Because I think one thing that happens with the SAS tutorial is it doesn't really stop to answer the question, well, why would I ever want to do this? I've already shared with you that you will use this in biostatistics, you will use it in epidemiology, but more importantly, you're very likely, more than likely, to use some form of statistical software in your work, whether it's to do quality improvement projects, whether it's to do research, whether it's just to crunch some numbers that you want to report out. And so I'm going to give a concrete example of using SAS to answer a question that you might actually be interested in. I know in the tutorial, I'm sorry, in the video that I posted online, the presenter did a nice job of kind of creating some enthusiasm around SAS. Unfortunately, the one example she used where she brought in data was something like a party invitations. So I want to give you something a little more concrete as far as real world applicability to something that you might actually want to do. So you don't have to follow along necessarily in terms of taking notes or understanding exactly everything that I'm doing. I just kind of want to demonstrate some of the things that one can do, and also kind of how I go about starting to see whether a data set is something that's going to be useful for doing maybe a richer investigation later. Okay, so with that background in mind, are there any questions up front that any of you have about the SAS tutorials or anything like that before I get started? Okay, so I will allow time after. I just didn't, if anyone had any pressing questions, thought I would address those up front. Okay, so I will share with you my screen here. And hopefully you can see my SAS Studio session. And I hope that all of you have been able to register for SAS and get your login credentials so that you can see something similar to what I have in front of me. So I've already been doing some playing around in SAS, so it's not going to look exactly like it does for you if you've just gotten started. But you will see some folders that may be familiar. If you set up your data correctly, you should have this EPG1v2, which is really easy to remember that name, folder. And in there you have your activities and data sets that you're using. And that's great. It gives you some practice data sets. But what we would really do with SAS, once we get it up and running, is use it for things that we want to bring in to analyze ourselves. So I'm going to share with you an example. So this is the National Ambulatory Healthcare Survey. It's actually a very useful resource for cross-sectional studies of healthcare utilization in the United States. Basically what they do, and it's actually the employees of the census who are trained to go in and abstract information from medical records, taking a random representative samples of all visits to hospitals. And so it kind of crosses boundaries as far as what type of database they're using. You know, at one time, there were all kinds of different competitors out there for electronic medical records. A lot of people now are using Epic, but even then, there's a lot of lack of standardization in healthcare information. So they went in and coded this data, abstracting the information to allow us to get a better handle on who's presenting to emergency departments in the United States, who's presenting to outpatient clinics. And they capture a fairly rich amount of data, similar to what you'd have in an electronic medical record. The problem is it doesn't have any, at least the older versions of this data don't have any follow-up on the patients. It's just what happened at that visit. But you can look at things like what was prescribed. So if somebody came in for a certain condition, how many left the office receiving specific medications, and those kinds of questions. So utilization questions are what this data set is all about. And I just happened to pick this one as a more relevant healthcare type of data. I have used this data for some small pilot research projects, and it's really good for looking at trend data. So without further ado, just to show you where the data originated. So basically field workers would go into hospitals and they would have a protocol for selecting at random specific medical records. And they're capturing just using a paper and pencil form. They may have an electronic input at this point, but in the old days, they would have just gone in and entered this information straight from a screen from an electronic medical record. So what type of insurance, where the patient is, are they at a nursing home, they live in their own home, their sex, their ethnicity, their age, race, insurer, how they arrived to the hospital. So this is for the emergency department. A bunch of vital signs, how long it took to get to the ED, whether they were conscious or not upon arrival. And then they also capture things like the reason for the visit. And these are standardized codes. So it could be like head trauma would be an example, or some other type of reason. They also have a text version where you can enter in kind of the underlying cause. So they were in a car accident or something like that, if there wasn't a specific code. And then they go into a different detail on injury. If there was an injury, was it intentional or unintentional? So this actually is a fairly good data source for looking at things like overdose visits and suicide attempts and anything that's injury related. It's actually a fairly rich resource. And of course, injuries are often seen at the emergency department. So another reason why it might be useful. They capture any diagnoses that the patient has. Now, this would be based primarily on, well, if they already are a patient of that hospital or that system, they would have what's called a problem list, which would be the different conditions that they have listed. They may just simply collect some of this information on site, similar to when you would go in for an office visit and be asked if you had specific conditions. So the reliability of this diagnostic information, as far as pre-existing conditions, may not be 100% reliable. They have what kind of screenings were done, lab tests, and then fairly interestingly, they also have the medications that were given during the visit and upon release from the visit from the ED, which if you're interested in opiate prescribing by EDs, which was a huge issue and still is a huge issue in terms of understanding the opiate epidemic. That this was a fairly, or is a fairly good resource for looking how much that's happening and trends over time. And then any of the providers that were at that visit. So it's actually a fairly rich amount of information that's collected on each patient, very similar to what you'd have in an electronic medical record. So I just wanted to kind of give you a background as to what the data entry looks like. What we're going to look at is the aggregate of all the data that was collected. Not only that, but from the five most recent years of data for this study. Okay, so that's what the data. That's like the raw data entry side. They would take these forms, they would enter it in, and then they'd create a database with all of this information in it. So if I go to, and again, you don't have to follow these steps because you're not going to be doing this now, but if you were to want to do your own research, there are data sources out there that allow us to answer some pretty interesting questions, some fairly timely questions. And in fact, when the data for 2020 comes out and the data for 2021 comes out, we're going to have a cross-sectional study or survey of hospital visits, outpatient visits during the COVID era. So it'd be kind of interesting to see what kind of presentations there are. Also, was there a decrease in presentation for certain injury types? And this data source may actually be one of the most reliable ways to gauge whether people maybe were avoiding coming to the emergency department for specific conditions. I know in the news, we've heard stories about that where patients, especially earlier in the pandemic, were afraid to come to the hospital for fear of contracting COVID. Obviously, we can't gauge their fear level, but we can look at things like, was there a sudden decrease in the rate of people presenting with conditions? And we may be able to attribute that some to COVID-19. That was a little bit of a sidetrack, but there's all kinds of questions that you could pose to this data because it is so representative of what's happening in the US, which really you can't say that about very many data sources in the US. We have a very fractured healthcare delivery system. We have a very fractured set of data tools to look at what's happening in healthcare. That's getting better because we are starting to get things like claims databases and other things that allow us to look at broader cross sections of the United States. But by comparison, for example, in Scandinavia, some of the countries there, they have 20 years of healthcare data with longitudinal follow-up on patients. And so using that kind of data for looking prospectively, it's a lot richer. In the US, we have to work a little harder to answer basic questions about what's happening in healthcare, or to look, and it is getting better, but it also it gets more challenging in terms of the data part of it. Okay, so this is an archive of different years of data. You can see that for the ambulatory medical care survey, it goes back to 1993. There's a, for the current version, but there's an older version that goes all the way back to 1973. So they've been doing this for a while. And then the hospital survey, they've been doing since 1992. So there's lots of documentation on here, but you'll notice right here, the first data source, or I'm sorry, software package listed is SAS. They also have SPSS data. They also have STATA data. So I mentioned before that there are competitors out there for doing statistical software. SAS is the more robust as far as documentation, and they have kind of preloaded code book and things like that for SAS. For the other programs, it's they give you access to the data, but it's not all labeled and things like that. So they're being nice to us. And they had these nice pre-made SAS data sets for 2015 to 2018 from the ED data. So I'm going to access that. And I will show you what that looks like. Let's see here. I am going to go to, just give me 1 second. Open a new window. It's just going to take me 1 quick second. I'm just going to throw in an extra FTP. Okay, so this looks like a little bit intimidating, but this is sending me over to a listing of all the data resources that they've archived here. So if you're unfamiliar with this layout, this is kind of old school way that data would be stored. And I can see right here that there are these zip files that have the ED data for 2015, 2016, 2017, and 2018. So this is nice, rich, raw data that I can, without paying any money, can do some basic research or answer some basic questions using this data. I might even want to, let's say I'm a hospital administrator and I want to compare my hospital to the rest of the United States. I might say, wow, I have a disproportionate number of patients who are presenting with some condition. Like, is this typical? Well, this would allow you to say what's happening across the United States. You could even look at things like rural versus urban settings. You can look at different state geographies. I think it's robust enough to allow you to look at state level. But anyway, so it's out there and available. And there's a lot of other data sources like this. I just happened to pick this one because it's fairly easy to use. And it's pretty rich, and some of you may actually want to use it for a project. So I'm not going to go through the whole downloading of the data. I'm sure you all can figure that out. I'm going to right click. It'll extract the data to my downloads folder, and then I'll unzip each of those zipped folders. And I'm going to spare you that step because it's fairly time intensive. These are fairly large files. But just know it should take like 10 minutes to do that part. Okay, so let's assume that I've put these in some folder that I know the location of. Now I'm going to go back into SAS Studio. And I am going to, first of all, I am going to move this little bar from Zoom out of my way because it's blocking my view. So I'm going to create a folder over here, and I'm going to give it a name. And I'm going to be real clever. I'm going to call this NHAMCS data. Okay. So now I have this folder over here in my server files and folders. So that was my first step. This is where I'm going to put this data that I downloaded from the internet. Until you have a folder, you can't just you have to upload the data to someplace. So it's a little confusing. If I'm not in a folder, you won't get the little upload button. But if I go to now if I click on NHAMCS data, which is a folder that I created, I can upload files. Okay, and it's asking me to choose files, and it should take me to my downloads. Okay, and then in each of those folders, I have my different years of data. So I will show you this step just to show you. I know I'm doing this really quickly, but okay, and finally, make sure I get them all. Oh, downloads, that's where I was. Which one did I not do? I guess 20. Okay. Okay, hopefully that's everything. Okay, so I should now have in my enhance this data the folder that the data that I just downloaded. Okay, so now that I have this folder that I've created, I can use that SAS data that's in there. And I'm going to cheat a little bit because I created another one. There we go. That already has it in there, all the files I want. Okay, so I have these 4 files, ED 2015, ED 2016, ED 2017, ED 2018. Okay, so the way that I downloaded those data sets, they were in separate files, which is fairly typical. I work a lot with claims data, and it's kind of the same thing, you know, hundreds upon thousands of records for a given year. And so often we have to append data sets. And in this case, the structure is exactly the same. I'm just stacking them on top of each other. Okay, so my first step is going to be, let me create a new SAS program. I might cheat a little bit because I was playing around before. So the first thing I want to do is I want to do a libname statement, which is invoking the location of this data. So this folder is not a library. This is just a where I've uploaded some data. So in SAS world, I have to assign a library to this physical location. A library is just a shorthand way of referencing some data. So I'm going to call mine, same thing, NHMCS. And then I have to tell it physically where it is. So I'm going to right click on this and select, sorry, my little doodad here keeps getting in the way. Properties, and it'll give me the path, that folder. Okay, so now all I've done is create a SAS library, which you'll go into in the tutorials if you haven't already. And I've basically just given it this made up name, NHAMCS, and told it a physical file location. Okay, and a libname statement doesn't need to do a run statement. I'm going to just click on this little running guy, and that's going to run statement. And it says it successfully created this library. Woohoo! Okay, we're off to a good start. Okay, so my next step is going to be, well, I'm not interested in just 1 year of data. I'm going to combine these different years of data. So I'm going to do a data step where I'm going to call it all data. Oops, I'm sorry. I got to do the library name first. So NHMCS, and then I'm going to, that's the library name, and then I'm going to say all data. Okay, it's not that clever a name, but I'll go with that. Okay, and then I'm going to say set, and then I'm going to put each of these. Oops, didn't mean to do that. Sorry, I thought it would just save me from having to type it. NHAMCS dot 20 ED 2015 NHAMCS dot ED 2016 NHAMCS dot ED 2017 NHAMCS ED 2018. Okay, so what I've done here is just I've said in this new data set that I'm creating called all data, please put within there these 4 data sets, ED 2015, ED 2016, ED 2017, ED 2018, okay? And so I'm gonna click on this and say run. Hopefully it'll all work. Woohoo, okay. Now, I happen to know that these are not error messages. These are just notes, these little blue things. If it's in blue, it's all good. And actually, I know it's going well because not only did it work, but it actually opened up the combined product of those data sets for me. So you can see here, I have this data set with 77,528 rows. That means there are 77,528 records in this data set. And the columns, 1,058. That means there are 1,058 measurements taken on each patient. So if you think about a spreadsheet, each column is an observation, or in this case, each row is, I'm sorry, each row, let me take that back. Each row is an observation. Each row is a visit by a patient. Each column is one of the measurements that were taken. So I imported this data from this source and the CDC, and the default was to just show me the first 10 variables. So the first 10 variables, there's little check marks here. The first one is the month, which if I look down here, it gives me a little more information about the variable. When I imported this data, it also imported kind of a little code book that tells me a little bit more about it. Sometimes you get data and it's raw and you kind of have to refer to a physical document. But in this case, it has a little bit of information. So this is the month of visit, okay? Visit day, that's the day of the week. So 1, 2, 3, 4, 5, 6, 7, those are the days of the week. Was it Monday, Tuesday, Wednesday, Thursday, Friday, or Saturday, or Sunday? You know the days. The arrival time, or the wait time, and that would be at the in the ED. Length of visit, LOV. Double check, make sure. Length, yeah, in minutes. The age of the patient in years. Age in days. I guess if you really want to be precise, you can figure out their age in days. Okay, and all of these things they mirror what I already showed you in the survey. The order that they're appearing in this data set is roughly the same as it was in here. So arrival time, the age is obviously derived from their date of birth. Oh, I guess there's also an age field. Okay, so a lot of the information that's appearing here is just the aggregate version of all that information. Ethnicity. Okay, then we start to get into some of the vital signs, temperature, pulse, blood pressure. Okay, and notice by default it didn't give me all the variables. It's because there's 1,000, and that would create a really wide data set. But I can look through these different variables, or these different columns to see which ones I'm interested in. I could also go back and refer to the documentation and read through and select the variables that I'm interested in keeping. Often there are variables that you would never use. So if I don't really care what time of day they arrived, then I might get rid of that variable. But for now, I'm just going to keep everything in here. The most important things I'm going to look at today is they have reasons for visits. That's the RFV codes here. And again, this is unique to this data set. So they just created these shorthand variable names referring to those items that were on the survey. And then they have causes of injury, and then they also have diagnoses. Okay, so diagnosis 1, diagnosis 2, diagnosis 3, diagnosis 4, and diagnosis 5. So at each visit, they capture up to 5 distinct diagnoses. This is not the same as the stuff that was in the problem history. So like if they have asthma or if they have history of diabetes or all those things, those are captured elsewhere. These are diagnoses that occurred during the visit. So if they presented with a heart attack, that'll be here. If they have presented with some other or any condition that was diagnosed at the visit, it'll be captured here. And usually 5 is enough to capture what is happening in the event. And normally they would take the primary reason as diagnosis 1, any secondary diagnoses 2, 3, 4, 5. Okay, other things might be captured in the problem list. Okay, so I'm going to focus today on a potential question one might have with this data source. And I could go through you and show you more of this, but really it just kind of mirrors what's in here. So for kicks and giggles, I'm going to do a quick little study that I might be interested in doing using this data, okay? And this is just a hypothetical situation. So I'm going to say I've noticed that a lot of concussions happen in my clinic during the fall months. When kids are, or especially when kids are in school, I see a lot more concussions in my ED than in the summer. I see a lot more in the school year. And my hypothesis is it might have something to do with school athletics, but we'll just save that for now. I'm just kind of curious to see if the pattern that I see in my clinic is typical across the country, okay? So again, knowing that this is representative of the entire US, I'm gonna start to dig in and see if I can answer this kind of basic question. So let me go back to SAS Studio, and I've got my program. Oops. Code. Okay, so where are we right now? All I've done so far is read in some data, okay? Usually what I would do next is some kind of just quality assurance. Just make sure that it read in right, things are looking okay. So I'm gonna do a quick little procedure. And I'm going to say proc-freq, which is procedure frequency. Frequency is one of the procedures that are often used in SAS. And frequency is just how often does a certain observation occur. And I am going to tell it which data, NHAMCS, all data. Okay. And then I'm going to say table, which is the next within the proc-freq statement. That just happens to be the structure. These are things you're going to learn in your tutorial. So I'm going to say table year. I happen to know that's a variable in here. Usually year is in the data set. It might not be spelled that way. Maybe it's V year for visit year, but I'm just going to take a stab at it here and see if year comes up. Woohoo, it did. Okay, so if you're hopefully you're able to see this. I hope I'm not just talking. Okay, so you can see this, right? Okay. The year is 2015. I'm sorry, for the year 2015, there were 21,061 records. In the year 2016, there were 19,467. 2017, 16,709. And in 2018, 20,291. Okay, and I wasn't actually interested in that question. I was just making sure that everything looks right, that I didn't accidentally make 2 copies of the same year. And like I've got two copies of 2015 and one of 2017 and 18. So doing quick little checks like that before you even get started can save you a lot of headaches, because it would have been really easy for me during those download steps to make a mistake, change a name, do something like that. So you always want to kind of make sure that what you're looking at is what you think it should be, okay? And I usually start with some kind of very simple check like that. Normally I would do a few more checks, okay? So let's say I want to say, okay, well, I just want to know overall, how old are the patients who come into the emergency department? Okay. So I'm going to do another procedure here. I'm going to do proc means. I'm going to use the same data statement, data equals NHAMCS dot all data. And in this case, for this particular procedure, and again, these are just things you learn, as you go. I'm using a var statement, which is what you variable, okay? And so I'm going to say age. So all I'm going to do is figure out what is the average age of patients in this whole data set. Okay. And usually if everything goes right, you get output. If you had an error, you're not going to get output. So the fact that I'm seeing output, I'm not even going to go look at the error messages because this is what I wanted. So out of the 77,528 records that are in this data set, the average age of patients is 37.95. Okay. So 38 years old is the average age of people who present with ED. And that would be true of the US as a whole for those 4 years, so the average person. Okay, that's, I guess, interesting. You could look at the distribution of age, but don't forget, my hypothesis was that at my hospital, I'm seeing a lot more patients who are presenting with concussions in the non-summer months during the school year. And I want to see if this is true nationally. So, okay, my next step, go back to my code. Okay, so clearly I've got this whole age distribution of different people, and their average age was 38. So I am, out of curiosity, going to do a proc freak. Oh, I'm sorry. This is an important step. Now I want to find out who had a concussion in this data set. Now this is going to be a little bit trickier because there's no variable in here that directly says, did they present with a concussion or not? I'm going to have to use another resource, which is my knowledge of where to access the ICD-9 or ICD-10 codes that correspond to a diagnosis of concussion. So this data is 2015, 2016, 2017, 2018. 2015 is the year that the coding switched over from ICD-9 to ICD-10. So all of you in healthcare need to know this. ICD-9 switched in October of 2015. So I'm actually going to have to, because the years of data that I'm pulling from span that change, I'm going to have to use codes from 2 different years. Okay, so if there's nothing in this data set that's going to tell me what those codes are, so I'm going to use the internet. Let's see if I can do that while you're still looking at my screen. Okay, so I'm going to do ICD-9 concussion. I have my little favorite resources here, but okay, yeah, this is the one I want. So I was real clever. I went in, did the ICD-9 concussion, and I happen to know that this data set, this resource is really good for looking up ICD-9 codes. So concussion, I'm going to look a little closer here. So it's 850. Okay, concussion, 850 is the prefix. And then there are little subcodes here. So 850.1 is concussion with brief loss of consciousness, concussion with loss of consciousness, blah, 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 blah. So if I was really specific, I might say I'm only interested in ones where they lost consciousness or something, but I'm going to say all concussions. So my prefix here is 850, and that is the ICD-9 code for concussions. So I'm going to go back to SAS Studio. Oh gosh, I've already forgotten it. 850, okay. Okay. So I'm going to say concussion equals 1 if dx1, no, diag1, that was the variable name, equals Oh no, I want to do this in 850. Okay, so I just gave it this command, which was concussion. I'm going to assign the value 1, meaning yes, if diagnosis 1 starts with 850. So this in colon is a shorthand way for me to say if the first 3 characters are 850, I want to select that. So 850.0, 850.1, 850.9, all will be captured with this statement. I'm going to repeat this for each of the 5 diagnosis codes. Usually you're doing this under the relaxation of your own. Okay. But right now I've done this coding kind of without much thought. I'm just writing this down for my own purpose. So to make this a structured statement, first of all, I need colons or semicolons at the end of each of these things. And I also need, oops. I did the opposite language. Oh gosh, I was using SAS code here, or Stata code. Oh no, okay. I just need to change this. If, so this is a problem when I go from using Stata to using SAS. I'm telling you, I'm making this up as I go. No, I'm actually creating this code as I go. Okay, so if diagnosed in that, then concussion equals 1. Okay. And I'm going to cheat a little bit here, or not cheat, I'm going to copy that. And it's okay to make mistakes. You cannot break anything. I know I sound like Bob Ross doing a painting now, but you can play around in here. You're not going to break anything. Okay. So, okay, so if diagnosis in 850, then concussion equals 1. Okay, that's the correct code. I first need this say concussion equals 0, because I'm going to set the rest of the records that aren't true for this code. I'm going to set those to 850. Okay. I also need to create, I'm just going to call it data A. Set. Okay, so I'm creating a new copy of this NHAMCS all data because I want to preserve the original combined data. Everything going forward here, I'm going to do this kind of my work in the working directory. So I'm just going to call it data A, and I'm telling it to put into that data set A my all data. Notice I didn't put a library name. When I just say data A, that's creating a temporary data set in the working directory. So it won't actually create a permanent data set, but I'm just doing this for the purposes of looking at this data right now. So I'm just going to call it data A. Okay, well, I'm almost done with this step. The problem is that in ICD-10, the diagnostic code for concussion changed. So this is something you have to be very mindful of when you're looking at data. So I'm going to go back to my ICD-9. And they have this nice little convert to ICD-10. Let's see if it does it right for me. Yeah, okay. Okay, ICD-10, I don't like ICD-10. SO6.0x0A. It's so not happy as far as how they started with letters and then, okay, so So SO6 refers to intracranial injury, which is not specific enough. And then within that, concussion, SO60. Okay, and similar to ICD-910, which is the old coding system, you've got concussion with consciousness, concussion without consciousness, etc. So the root that I want is this SO60. Okay, so using the same logic, and I know I'm moving kind of fast here, but I'm going to copy and paste all this. And instead of 850, I'm going to say SO60. Okay, so all I'm doing here is getting this, defining this cohort of patients that I'm actually interested in who had concussions. Okay, so what have I done? I'm creating a temporary data set called A, and in this statement, I've created a bunch of statements saying if the diagnostic code across diagnosis 1, diagnosis 2, diagnosis 3, diagnosis 4, diagnosis 5, if it's a concussion, I'm going to call this concussion variable that I just created 1. Otherwise, it's a 0. So basically a yes, no, is this a concussion? And I'm going to do run. Okay, so if there's no errors in my program, let's hope for the best. Yay. Okay. I know it worked because it created a data set here. This is a copy of the other data set. I could also look at the log. There's no errors. Okay. All right. So now I have a slightly more powerful, useful data set, which is now I've identified patients in this data set who had a concussion and those that didn't have a concussion. Okay. The majority of people who present to the ED don't have concussion. So they present for other reasons. So I'm curious now. I'm going to say proc freq data equals A, because I have this nice little small data name now. Table concussion run. Okay, so what this is a big moment, folks. If you can't tell, I'm going to determine how many concussions were present in my data set for these 4 years out of all visits to emergency departments that were sampled, keeping in mind that this was a representative sample of all emergency department visits. This is what I've got to work with. Oops, what did I do wrong? Data equals A. Oops, I misspelled concussion. Of all the things. Concussion. Okay. Try that again. Woohoo. Okay, like I said, mistakes happen. So concussion, there were 408. A little disappointed, not that there weren't more concussions in the world, but to answer my question about concussion. So out of the 70,000 of visits to hospitals in this survey of visits, only 408 were concussion. I'm a little surprised it's that low, but there's a lot of things that people go to the ED for. So that's how many were actually captured in this survey. But I'm interested in the seasonality of concussions. Maybe my hypothesis was that during the school year, I'm seeing more concussions, and maybe I need to staff up to have more people who can do those kinds of screenings in the ED. So in case somebody comes in, they can do the quick assessment. So I'm going to go back to my code. All right, so now I have identified a cohort of patients presenting with concussions. Now, I'm going to say, when did people who present, what month did they come in? Don't forget, I was thinking that it was in the school year that they presented more frequently. So I'm going to do proc freq data equals A, table visit month. Okay, this is the month that they visited in the year, and run. Oh no, where concussion equals 1. Okay, so I've added this time a statement that says, under this condition of where they had a concussion, what month did the patients present? So I'm going to run this. Okay, so out of my, the screen is so tiny. Out of my, the 12 months of the year, 33 presented in January, 25 in February, 30 in March, blah, blah, blah. Okay, 45 in August, 45 in September, 35, 55, and then 16. Okay, well, there is definitely a jump. One could argue, or a slight dip in June and July. There's 26, 22, there's 45 in August, 45 in September, 11 in November. Obviously, this data set is not super rich because there aren't that many events of interest, but I'm just kind of curious to see if there's a pattern here, okay? Well, don't forget, this is among everyone. And so I'm more concerned about school age kids, not just everyone who presents with a concussion. So the seasonality may not be there looking in the aggregate, but let me just limit this now further, where concussion equals 1 and where, and age less than 20. Okay, I don't know, kids graduate high school, maybe 18 would be better, we'll leave it 20. Okay, so I'm just gonna make a slight modification to that data. Okay, so now I've isolated the data further to looking at school-age children only, or people under 20, and the times a year in which concussions are happening, presenting to an ED. Okay, well, in this case, now I see that in June and July, I have 4%, roughly 4%, 5, and then in August, it jumps up to 10.9% of the total. In September, 14. Okay, and there is a dip in December back down to 4. Okay, so there seems to be some preliminary evidence that what I'm seeing in my clinic is also what's happening in the nation. There are a slight dip in summer months, if we're calling June and July summer, and we are seeing more in the school months. This is probably not a publishable paper analysis, but I was able to kind of zoom in here and look at a very basic question, which is, when do concussions present to an emergency department? And I have a comparison data set here that I might reference for comparing my own hospital, or if I was doing more of an epidemiological study where I might be interested in the role of sports and concussion, I might construct a bigger data set and look at maybe some seasonal effects in the frequency of concussions. Okay, so that is my very quick and dirty data analysis. I wasn't terribly satisfied with the result in that there were only 400 concussions to begin with in this data set. And that's one thing you always want to kind of think about as you're approaching research questions and doing research is, well, will I even have enough people in my study to look at the question that I'm interested in? So say I'm interested in something else like asthma and asthma hospitalizations and how many of them went home with an inhaler after their asthma. I could look at that data, and maybe there's enough in this data set to look at those kinds of questions. But you always want to do these kind of first pass looks at data sets to say, hey, is there even enough data here for me to work with? Often in epidemiology, we would, if we're really interested in a topic, we would create a study where we assure that we have a certain number of participants in the study and we follow them over time, et cetera. This is just using secondary data to answer some questions that we might have. But I just wanted to give one example of the types of things that we can do with SAS. I realize it wasn't the most exciting result, but this was just one short example. Okay, so any questions based on what I did? I know I went kind of fast. Okay, needless to say, there's tons more I could do with this data set, but I'm just gonna toss that one out. That was just for kicks and giggles. Okay, so I'm gonna switch gears here. Let me share, and I promise I'm going to get you guys involved here shortly, maybe. Okay. Okay, major shift of gears here. So I'm going to talk briefly about the importance of interprofessional education and collaboration. And this may sound kind of abstract or not terribly interesting at first glance, but really it's becoming the norm in medical education and in public health training to take an interprofessional approach. And what that means is rather than just relying on one group of professionals, just doctors or just epidemiologists or just nurses or whatever group, that we work together to solve public health problems. Perfect example, COVID, right? We've got people at all levels of healthcare and public health working together to battle COVID. And that includes not only just your traditional folks, but you've got police and you've got EMS and you've got all kinds of different things you have to coordinate. So interprofessional, it kind of comes naturally to us in public health. In medicine, however, it's relatively new that medicine was considering what was happening outside the hospital walls and to interact with people from different professions outside of medicine. And even equally rare was for there to be opportunities for learning among nurses, with doctors, with social workers who work in hospitals, with other people who work with patients in the hospital setting. More and more education in healthcare is moving towards this interprofessional education model. The idea being is we all have to work together in the real world. Why don't we do our training that way? And there are some medical schools now where they've really embraced this model. Where I did my graduate work in epidemiology at Case Western Reserve University in Cleveland, they have a medical school affiliated with the Cleveland Clinic, and that's exactly how they're doing it. They train their nurses, their PAs, their nurse practitioners, up to surgical folks within the status hierarchy of medicine are taking courses together during their training, so that when they get into the work world of actually being doctors and nurses and everything else, they'll already have had opportunities to see it from different perspectives and to learn together, to solve problems. It just makes for a lot better. So I probably don't have to, I'm probably preaching to the choir here, but interprofessional education is really important. The definition of interprofessional education is simply when people from two or more professions are present in the same room and they're learning together. Okay, so my guess is that right now in this room, as quiet as it is, it's just me, and that's not your fault, that's just how this works right now. there are different health professions represented in this class. I know we've got several doctors, we've got a phlebotomist, we have other backgrounds in health. And so right now we're doing interprofessional education in a sense. But so that's really the basics of interprofessional education. Interprofessional collaboration is when multiple healthcare workers or public health people from different professional backgrounds work together with patients, family, caregivers, and communities to deliver care. Okay, so you could argue that collaboration is also a form of education. That's kind of how we learn to work together, is through collaboration, actually doing collaboration. But often interprofessional education would be those seminars, continuing education courses, workshops, things like that we might do together. And I really encourage you to think about yourself as a health professional and take advantage of those kinds of interprofessional education opportunities. It's a lot easier if you're on a physical campus, but there are lots of online opportunities for learning. I am currently getting prepared to take the WELL AP exam. WELL is a building initiative to make buildings healthier. That includes everything from design to airflow to the psychological benefits of plants and kind of this environmental psychology stuff. And it's kind of a new field for me. I was sort of involved in this work previously, but there are architects, designers, planners, and then there's the health folks and the epidemiologists and stuff in the room. And I found it really interesting to see the different perspectives. So there's all kinds of ways that you can do that outside of your MPH program. And as you embark on your careers, think about ways that you can intersect with other professions. So where did it come from in healthcare and public health? Why did we start to move towards this model? Why didn't we think of it sooner? Well, one of the reasons it started to happen on a bigger scale is that hospitals started to do what we call continuous quality improvement. They recognize a problem or a process and they want to fix it. Maybe they're having too high a rate of infections among surgical patients, or there's some other thing that they want to improve. Well, to improve on that particular metric, you have to get everybody to the table. You can't just get the doctors or the head of the hospital or one level. You've got to get the whole, from the person who sees the patient when they walk in the door, that could be a receptionist or even a valet, to the doctor who actually performs the surgery or whatever. Continuous quality improvement often tries to involve multiple tiers within a setting like that. So that's one area where collaboration is kind of built in or was necessary to achieve those kinds of endpoints. There's also been a shift towards patient-centered care, where the things that we measure aren't just clinical measurements anymore. There's a lot of what we call patient-centered outcomes, where their overall experience in healthcare settings is what is important. And that's a much more nebulous and holistic view of healthcare at the same time. And so because we're starting to use these measures, all the more important that their experience of interacting with health professionals needs to be at a certain level, a certain standard, that everyone is trained and everyone's working together. And if there's tensions, we work them out, because the patients are likely to pick up on those kinds of things if things aren't working smoothly. They pick up on culture, especially if they're overnight or something in the hospital. So all those things, that's another reason why we've kind of made the shift within healthcare. Public health, like I said, we've always been collaborating. Another area I already kind of hinted at was in infection control. If you want to control infection in a hospital, you got to get everybody involved. Everybody has to wash their hands. Everybody has to adhere to protocols, janitorial staff, things like that. Infections don't care who the person is that they're attaching themselves, or whose shoe or whatever. Like, so infection control is another area where a lot of collaboration is needed to affect change. So those are sort of some of the reasons why this has become such a big movement in healthcare. And this relates to the triple aim movement within healthcare to think about improving patient experience, improving the health of populations. It used to be that hospitals had no real accountability to the neighborhoods or the communities that they serve. More and more so, they are accountable for the health of the local population. And so that's another area where public health has been brought to the table more by healthcare folks, because we're needed to help them achieve certain targets with respect to the health of the population. And then there's been also a big movement to reduce waste and to improve, reduce the costs of healthcare. And that also requires a lot of collaboration. So that's another area where, another reason why this has come to be. And it really is the way forward in education and in training across settings. As I mentioned, we do this all the time anyway. We are in public health, we're used to doing collaborative work. And in fact, if you think back to John Snow and the cholera epidemic, he asked the police to remove the handle from the water pump, and that put an end to the cholera epidemic. If you haven't heard the story of John Snow, you can Google it. He's one of our our heroes of epidemiology, along with Florence Nightingale and a few others from back in that area. But yeah, social workers, interpreters, public safety folks, government agencies, community organizations, all these types of groups we work with in public health to achieve our goals. So it kind of comes naturally to us. So I don't have to sell you too hard on interprofessional collaboration. But I think what we're going to see going forward, and I know we're getting close out of time here, but what we're going to see going forward is much more integration beyond the traditional boundaries of the groups that I just mentioned, but architects, urban planners, data scientists, journalists, teachers, church and religious leaders. Think about how important all of these groups are or have been for the COVID pandemic. And things like mental health first aid training. We need to do a much better job of getting more people trained in doing basic mental health first aid. And so teachers could be people who perform that kind of work. Journalists, we need to get them to message, to cooperate as far as messaging to the public, to make sure that when there's information to get out, that it's done in ways that are going to be effective in terms of reaching our goals as far as putting an end to the pandemic. And that doesn't mean to be biasing them, it means to be providing them with information to let them know what's going on and to communicate well with journalists so that we get the message out to the public. Because often we do rely more and more on the media to get the word out. So those are some examples of some sort of emerging collaborations. And I invite all of you to think about trying to invite these non-traditional professions to the table when you are thinking about doing projects. And more, collaborative teams are required for pursuing funding or doing projects. If you want to get a grant to do a project, you should already have 2 or 3 partners lined up, whether it's a letter of support, just saying, hey, yeah, I know they're doing this and I think it's a good idea, or they're actually going to be, part of the team working on a project. So that's so often the case. And even within more traditional pure research settings, often the requirement is that you have multiple collaborators from different hospitals or different universities. I can't think of a project where we didn't at least involve other departments within the university, but usually it involves other institutions as well. So building those kinds of connections, building those bridges. The reason I mention this is that as you move forward in your careers, build those relationships because you will use them again. I can't tell you the number of times where I've gone back to mentors or collaborators and we end up working together on different projects, especially if you're working in a local community, you absolutely need to build those kinds of relationships. That's one of the things we're really good at in public health. So, you know, likewise, don't burn those bridges. You know, keep, you know, make sure that when you do work, you follow through and you do as good a job as you can, because you may need that support later as well. Okay, so there's a little pitch for doing collaborative work and just some examples of where this comes up. I've already mentioned several times COVID. Think about the effort that it took to deal with Ebola in West Africa. We sent over our military, we sent over supplies, we sent over volunteers. We had medical staff going from US hospitals abroad. We had to deal with transportation issues and policies and those things. Same, you know, that was kind of a preview of what we had to do with COVID. So those are examples where collaboration is absolutely key. Disaster response. You're going to have your medical reserve corps going in. You're going to have volunteers. You're going to have EMS. You name it. You need to set up a chain of command to deal with those kinds of things. One area that you could get involved with is actually some of the medical reserve corps around the country need non-medical folks to volunteer so they can participate in drills. They might do something like psychiatric first aid, something like that. So that's a nice collaborative opportunity to see what kind of trainings are available out there with your state level or local medical reserve corps. Mental health, community is really important in that. There's lots of opportunities to get involved. Working with complex social issues around vulnerable populations, homeless populations, HIV prevention, tuberculosis, just to name a few. These are all things that require extensive community level collaboration. I'm kind of rushing through this because I know I'm over on time. Okay, so some of the benefits of interprofessional cooperation, collaboration, improved communication, improved efficiency and efforts, lack of duplication of efforts. It's really good to know who else in town is doing the exact same thing as you. It does happen. It improves employee morale. I know it also helps to feel motivated in your career where you're working with different types of people besides the one that your own profession. Fostering creativity, different approaches. We often think in silos, and sometimes when we connect with different groups, just their perspective alone can invoke or create an opportunity for creativity, better problem solving, networking, and more importantly, we start to see better outcomes, whether we're talking about public health outcomes or clinical outcomes, the more we collaborate. So that's it for my formal presentation today. We'll pick up with this discussion a little bit next week. But before I check off, are there any questions anyone's having that they need answered? Well, thank you very much for taking time out of your very busy evenings and schedules. And we will check back next week. Again, don't ever hesitate to reach out to me by email if you have any questions about the program or about this course. You can even ask me questions about your other course if you're taking one. But yeah, don't hesitate to reach out. So thank you and have a good night.